Hello, I'm Dave. We're going to be talking you through our journey around looking at how we reduce the clinical admin in the children's neurodivergent pathway in Wales. And we'll talk a little bit about the AI scribe journey that we've been on. I'll be joined with Kim Morley as well later in the presentation. So there's a big problem in Wales. There's a huge waiting list for autism and ADHD assessments for children. And a lot of parents feel like this is putting the children's childhood on hold, that the child is struggling to make friends or they don't want to go to school, and the parent doesn't know how to help the child through this tricky time. And the numbers of the waiting list are quite big for these assessments. In 2021, there was 4,100 people on the waiting list, and this has grown significantly in the 3 years to 2024 to almost 21,000. And if things continue the way they are, the waiting list could grow to anything up to 61,000 people. And more people are getting more comfortable about talking about ADHD and autism, and there's some great programs on iPlayer by people, like prominent people like Kelly Bright and Chris Packman, openly sharing their experiences and interviewing people. So these are two great programs to watch. So, but the problem is that if you're an 8-year-old and you were referred today, you could be waiting till you're in secondary school before you get that invaluable assessment. That's a lot of time that's passed, which is a lot of stress for the family to learn how to help the child, but also for the admin teams that that child has been through the last 4 years. We need to get new information from them from different sources. So it's creating a bigger admin burden having that long waiting list. And the waiting list, yes, the numbers and yes, the time, but they're also that measure of that anxiety and lost opportunities and family stress that people are going through while they're waiting on that waiting list. And parents are desperate for people to listen to them. They have to fight for the basics to try and get mainstream education to help their children. That's a constant fight that these parents and carers are going through right now in Wales. So we were brought in to look at how could we reduce this waiting list? What could we do? And we're looking at it through an angle of a digital tool. Could a digital tool help with this? So the first thing that we did was speak to the people on the ground, speak to the clinicians doing the work, who face the challenges every day, who do the appointments with those parents and carers and children, and try and get an understanding of their day-to-day work. And we had a few questions, and one of them was, what does that neurodivergent pathway look like for them? Where are those pain points? And what are the opportunities to try and improve this neurodivergent pathway, perhaps with tech or perhaps with service changes? So we spoke to a number of clinicians, support workers, paediatricians, service leads, and we mapped out an end-to-end pathway of the neurodivergent pathway from somebody who thinks I might have ADHD or autism, right through to living with the diagnosis and everything in between. And we looked at the pain points with different systems, how people communicated, but we also looked at the innovation that the different health boards were trying to bring in to help alleviate this this waiting list and the numbers on that. And what we saw was that the clinicians are very people-led. They want to get to the children and help them. This is not just about a diagnosis, but during the pathway, they try and help people really early on, support them, fill out referrals, which help people get onto the pathway. So rather than people submitting them, having to redo them, they try and help them set up like working groups so they could fill out these forms together. Also setting up early support for people. A diagnosis doesn't necessarily get you help. The problem's there now. So how do I deal with someone not going to school or perhaps having a tantrum in the morning? So these early support hubs were there to give parents and carers information right now rather than having to wait. And in one health board, we saw the clinicians were having calls with parents and carers very early on so that the parents could feel heard and there was a two-way conversation. But more and more, we heard that a lot of clinicians were spending time doing admin work rather than spending time with the families and the children. And we heard from one clinician that 10 years ago, they'd spend 80% of their time was with the child and 20% with admin. But today it was more like 80% of my time is on admin and only 20% of time helping, giving that real value that they're bringing, spending time with those children and helping the parents and carers understand how to help them. And looking at all the different systems which were sort of like knitted together, the clinicians felt they were very much broken, which involved lots of manual copying and pasting information from one system to another to feed the bigger health machine across Wales. So we had a broad understanding across different health boards, but we knew there was a lot more to this. So we wanted to get in and spend time with clinicians and support workers to see their day-to-day. So we were lucky enough to spend some time in health board. We spent a day there with a support admin person and a team lead, and we observed them all day, looking at how they would enter data. We noticed they had big screens, they had spreadsheets, they were copying and pasting service users data from one place to another. We counted it in one place, there was 9 entries of a service user's name across those different systems, which creates a lot of data redundancy. And in between that, there was notes and trying to remember what to do, where to put things, and also the manual process of having to send out maps and where to get to your appointments through the post, etc. And often the systems are mandated, the systems that they have to use, that they have to put data in, the clinicians are often mandated by the org structure. So if I was under CAMS mental health, I would have to use a certain bit of software and put data in that to feed that CAMS team the information. So rather than being designed for the particular users, they were designed around the system to feed data, and they didn't always transfer all the data they needed to do. So this created a very manual process. So much so that people were creating checklists of which systems they needed to put what into, where I needed to store information, because it would take so long. There was a huge checklist, and then they'd have all these systems open, they'd copy and paste in information, which was a lot of, again, data redundancy. And this huge data redundancy was leading to real staff burnout. These clinicians are very human-centered. They want to help the children and the families, that's their expertise. But instead, they were feeding this data machine and burning out, which led to quite a high attrition rate, people leaving perhaps earlier than they should have done. And if we were to add another digital system to this, it didn't feel in the time that we had to replace things. It was more we were adding to this ecosystem. It felt we were just adding another layer on that people would still need to add, the clinicians would still need to add into all the mandatory systems, but then they'd need to add into this new digital system as well. So at this point, we started to think, well, how could we help the teams effectively without adding to the further cognitive load, to the further data redundancy? So we started to look across the journey that we'd mapped out and the tasks that people were actually doing. If you remember this quote, one of the clinicians, and well, a lot of the clinicians were telling us that they were spending a lot of time writing notes. And it didn't feel like it was like one major problem that we could solve. It felt like death by 1,000 like little tasks that all cumulatively added up to that 80% of time I'm writing notes, moving things about, copying and pasting, rather than spending that time with children. So we combined these and we looked together at what the sort of tasks were, and we were pulling information from PDFs, from Word documents that were from different doctors and pediatricians about the child, and combining that information, copying and pasting bits from that. Also taking notes in the appointments for ADHD assessments, for example, typing out what the children are saying or the parents are saying and that, but also getting that information and summarizing that, putting it into a format to be able to share with other professionals to discuss on what the assessment results are. But at this point, we started to think, how could AI help with these basic tasks, these admin tasks that clinicians were doing? We know AI could never replace what the humans bring, that real trust and ethical judgment and intuition of all that clinical training, understanding, and expertise. But it could perhaps help with just taking notes or pulling information together. So could we use AI to semi-automate some of these basic tasks that clinicians are faced with on a day-to-day basis? So one of the solutions that we've come up with is an AI scribe. You haven't heard of an AI scribe? It's a digital assistant which listens to conversations in real time, and it records the conversation, and it'll put that into a structured document which you can then use and share and summarize that. So it's like someone taking notes across a huge conversation or combining notes from different sources. So this in a nutshell, it works. You can pull Word documents, PDFs, you can put them into the AI scribe. It'll then feed into a template which can be co-created with clinicians, and then it can produce a report, or it can listen to the in-person assessments, pull out the transcript from that, put it into the AI scribe, put that into whatever template you need for that, and then produce a report. So we did some rough maths on this, and looking at all the tasks and thinking where the AI scribe could help, seemed like we could save us up to 8 hours per clinician weekly, which was massive. Could be up to 50 days a year. So there's a huge time saving benefit there. But it's not just the time, it's also being present and being able to pick up on everything that the service user, the child, the parents, the grandparents, other siblings in the room are picking up. And I'd just like to play you a little sample of what it sounds like in the room so you can appreciate the noise that might be happening as you're there as a clinician trying to take notes. So we'll just listen to that now.
Just sad. I had a meltdown yesterday when the fire alarm test went off.
As you can hear, like imagine 5 sessions back to back of that all day. There's quite a lot of noise going there, like quite a lot of concentration. And we heard from one of the clinicians, because of these back to back, trying to fit all these people and trying to get them through the waiting list. One clinician missed a parent describing a heart condition. And this was in our early trial that Kim will speak about shortly. That the AI scribe picked up on that heart condition, which the clinician would have missed if they weren't using an AI scribe. So already the clinician can be present, but the AI scribe can be like an extra pair of ears and hands to take notes that the clinician might not always be able to pick up. So the way we see it is that the clinician is still writing some basic notes, but they're also getting the benefit of having AI scribing more detailed notes that then can be summarized, or letters can be generated, which is a huge time saving there. And ultimately improving the quality of the clinician's notes by getting almost like an extra pair of hands to write notes, and reduce the fatigue of the clinicians so they can be more present for the full day back to back. And when we first showed the AI scribe to one of the clinicians, this is what they said: I knew within 10 minutes of seeing that this would make a huge difference. So really keen to get that into the clinician's hands.
Thanks, Dave. So I'm going to cover in the next couple of sections how we went from this point of feeling like we had this incredible opportunity that we'd recognised, and we wanted to know what steps to take next. We knew we didn't want to boil the ocean, but we wanted to do some short, sharp testing that would validate our research. We were also really aware of these ND teams being so busy and under so much pressure that we wanted them to do the least work so that we could learn the most. So all of these really powerful reactions we were seeing from clinicians on seeing a scribe demo, and with the pressure we know that they're under, how can we get something into clinicians' hands quickly? As we all know, within digital delivery, there's nothing as impactful as getting a prototype or any piece of technology, in fact, in users' hands, a real tool in a real setting, and seeing what happens. We had put a lot of research into a product called Heidi, but then we heard about a tool called Magic Notes, which is supplied by a company called Beam. And Magic Notes was already being used in different local authorities and social care settings. And when we spoke with the team at Neath Port Talbot, we had such passionate words from the team about using it. It seemed like a really good idea to dig a little bit deeper into what Magic Notes could bring. So we made contact with Beam and we set off working with them. The Beam team were really excited to hear about the opportunity to test with us, and we negotiated a really cheap pilot for them to allow us to do that real world testing with the scribe. And Dave and I know a fair amount about digital delivery, but we definitely needed more help. So we brought back together the people from the 4 health boards that had been really, really engaged with us in our earlier research. And instead of a formal steering group, we built a community of practice. So this is a really open, informal, no hierarchy group of people who come together to share their experiences. And those experiences were really great for Dave and I because they really helped us shape our work. And the biggest question that we needed help with was, so what testing should we do so that we can learn the most? So that was our focus from this community, to figure out what experiments to run. And we started out by asking, what do they know? Given what they know about an AI scribe, what are they hoping for and what are they worried about? So their hopes were really consistent. So across the board, they wanted to reduce duplication. They knew they wanted to free up time, improve accuracy, and allow themselves as clinicians to spend as much time as they could with patients and not doing paperwork. But of course, there were some fears as well. So clinicians were really worried about reliability, data security, and whether AI itself would just add another layer of complexity to their already overloaded brains. So hearing about these hopes and fears, that really helped us shape what we would do next. So we designed with the clinicians a set of experiments that we wanted to run. So we focused on 3 different types of clinical work. There was long assessments with new patients. There was short assessments for children who'd already been prescribed ADHD meds. And then there was a document-based experiment, which was pulling together lots of different documents to provide a clinician with a summary before meeting a patient. We thought that this variety was going to give us a really well-rounded view of the biggest gains, and perhaps it would highlight some of the bigger risks as well. Together, again, with the clinicians, we agreed the measures of success. So they knew what really mattered: time saving, accuracy, ease of use, and really importantly, how it felt to them, because we thought the improvement it might bring wasn't just time saved, but it was how that work might feel lighter for a team that are under loads of pressure. So we had to choose a place to start, which was really difficult because all of those involved in the community of practice were really super keen. But the team at CumTAF seemed to be lined up in a really great place and were already really keen to work with us. So that's where we decided to hold the first pilot, was in CumTAF. So this was all going really, really well, and we felt like we were in a really great place. And then we discovered that the hardest part to this whole thing wasn't deciding what to do or even the technology and complexity itself. It was, how do you turn this opportunity to test into a really safe, real-world test that will keep the patient and their data secure. So this is when we slow down a little. We knew that in order to get the pilot signed off, there were several steps that we needed to complete. But the problem was that the current pathways are built for really traditional procurement and rollout, and not for the small time-based experiments that we wanted to do. So a low-risk, tiny pilot like ours got routed through the full machine. And we understand why, especially as we were using new technology like an AI scribe. The IG team, the information governance team in ComTAF, were really thorough and constructive, but all of our challenge was that our proposal didn't fit any of the existing templates. So DPIAs and contracts had been written for conventional software, and that didn't map well to what we were trying to do with an AI pilot. So we spent a lot of time translating what we were doing into forms that weren't designed quite for what we wanted. So our original hope of 3 weeks, the reality was quite a lot longer. And then, we were stuck for quite a long time and we weren't sure what was happening. And our black box, funny enough, wasn't AI. It was the understanding internal governance processes. We didn't know which committee was signing what off, who was holding the pen, what information was actually needed from us so that the team would feel secure. So the result was we were completing forms. We didn't know if they were quite the right forms or if we were answering questions in the right way. But all of this is breaking lots of new ground for everyone involved. So we're really grateful to the help and support that we got from the ComTAF team. Because all this time we knew that our clinicians were sat waiting and ready, really desperate to give this a go. And the pressure felt really real. So that analogy of laying the track in front of the train, we really hope that the work that we've just done means that next time for other teams, this might be a bit simpler. But meanwhile, whilst we were doing all of this, we didn't also pause on our learning. We wanted to use the time to keep on learning, and luckily we were able to test our scribe in a really safe, controlled environment. We knew all along what the pilot would bring to us. We knew it would tell us about the value that an AI scribe can bring to that team. It would give us lots of data and a real way to demonstrate the potential impact rather than just talking about it. But we were also really excited when we heard about an opportunity to do some technical testing. So again, we got together with the clinicians and we designed some experiments to run in a university environment where we could test those really risky assumptions safely. And actually, what we wanted to do was figure out how far we can go before it breaks. So we wanted to deliberately push it. We wanted to test out different accents, interruptions, overlapping speech, background noise, poor Wi-Fi, all the things that might happen in a real setting, but they're really impossible to control and predict in the real world. And they were driven by lots of those fears that we spoke about earlier. So we knew that this testing was going to be really important to our clinicians. So luckily, we were in an incredible facility in Swansea University where they recreate real-world healthcare environments with professional actors and clinical staff. And here it is. So together we tested over 50 scenarios, really complex assessments, short reviews. We had real world variables like internet dropouts, bilingual conversations, people jumping up and down on chairs. So we really did take it as a stress test. Not does it work, but when does it stop working? And that is exactly what we learned, where the breaking points are. In each point of failure, actually gave us some ideas about what clinical guidelines we might want to put in place for anybody that's using this in the future. We used a calculation called word error rate. This is to help us measure the accuracy of the scribe. So we used this calculation. So what this means is that in every sentence, it's the percentage of words that were wrong. So the results, well, yeah, they were really impressive. They were genuinely impressive. It coped in loads of ways that we didn't expect. The word error rate was an average of 6.6 over all 50 tests, but remember that some of those tests were really out there to test the scribe with hands over mouths and all kinds of difficult things going on for the scribe to listen to. Without Wi-Fi, with slow 3G, it all still performed really, really well. With echolalia and scripting, so different ways of talking, it worked fine. It kept the developmental milestones distinct, and it even managed to capture nuance and tone. It worked really perfectly with accents, and it was incredibly well with all kinds of noise going on in the background. But we did see some stuff to look out for, which is what we wanted. So we spotted that it spelt names wrong quite a lot, but then don't we all? How many times do you say it's Rhiannon with 2 N's? The transcription halted once mid-sentence, and we didn't know why. Whenever there were quiet voices and noises in the background, it did cause higher error rates. And sometimes the bilingual speech didn't always capture that accurately. So all of this, none of them are showstoppers, and we've fed them back into our supplier as well to have a look at. So even with these limitations, it performed or matched the industry standards. So that was really, really encouraging. So off the back of that work, as I said, we started creating some guidelines for our clinicians, and we're hoping that they're going to hopefully be in the hands of some clinicians using it for real in the future. Just a quick glance at what some of them might be. Review, don't assume. The clinicians must stay the final authors of this record. Use as a support, not a substitute. So AI can definitely lighten admin, but it definitely also can't carry any clinical responsibility. So we built all of these into our testing report, and obviously we'd be, hopefully they will be useful in any future rollout. Meanwhile, back in ComTAF, whilst all this SUSIM testing was happening, things were finally moving along with the paperwork. So after all this months of groundwork, we got the software into the clinicians' hands, and that literally in this last week or so is when everything has started to come to life. So the pilot's running for 6 weeks. We're 1 week in, and with 6 clinicians in ComTAF using Magic Notes, we're focusing on those 3 use cases we talked about earlier. But we've also given them the freedom to experiment, and that really is coming up with some interesting results. We've set them up with a diary study so they can capture their reflections, and we have a WhatsApp group so we can keep feedback flowing in real time. Again, that's proven really interesting. And after just 1 week, this is a message from a clinician. She's going to quit her job if they don't keep using Magic Notes. And obviously that's something you don't hear this quickly, usually when people are testing software, and it shows how much they can feel a difference so early on. We've got some more direct messages from the team here, and you can see the kind of emotional response that it tells us that this is not just about saving time, it's really improving how people are feeling day to day about their work. So after 1 week, we've already got tons of data. We've got 5 users, 75 recordings, 37 hours of real clinical conversations already captured. Remember that this tool is brand new to the team, and yet they're managing to fit this in naturally into their day. So a combination of the enthusiasm we're seeing in the messages and the quantitative data from our diary studies. So we feel like we're in brilliant shape just 1 week in. The really interesting points that are so encouraging is as I said, the speed of adoption. These clinicians are using it naturally on the day of it launching. It's the emotional impact. So people are describing it as game changing, and we are going to have so much real data that is going to be hopefully translate into tangible time saving. So even after week 1, we can do some pretty good calculations on what that is. The super interesting bit is how low friction the launch of this has been within that team. There's been no system integration. It's just something that worked straight away. So that's incredible. So what does all this mean? We believe that the pilot results are going to show us what is possible. So to reduce admin, keep clinicians in control, and make their day lighter rather than heavier. And all of that is going to lead to, we hope, reduced waiting lists. So our next step is to put a second pilot in Haldar. This is going to give us a totally different context with a new team, new technical landscape, and some new processes so we can test how repeatable all of this is. But to make this real, we do have a lot of burning questions. How do we go from experiments to rollout? And, this is a really important thing that we need to consider. The team in Cwmtaf, already a week in, they love this so much. How do we take it away from them? This is a brilliant problem to have. It means that the demand is there and it's successful. And the answer is we're not sure yet, but we really hope that we don't have to take it away from them. Our biggest burning question is, who's rolled this out before within Wales? Because the truth is, for Cwmtaf, this has not been easy at all to set up. And in terms of information governance, it's a worry. So we'd really love to learn from others who've done this before. If there's anyone out there that can help us, then definitely get in touch with us. But before we finish, we really want to come back to where this all began. So we didn't start with AI. We started with a team in difficulties, a children's ND service team, stretched incredibly thin, spending more time on documentation than care. We mapped out the work, we listened to the team, we understood the bottlenecks and the emotional toil of the admin that they were doing day in, day out. And that's what helped us all together see this opportunity. Time and time again, we see that throwing technology at a team doesn't solve a problem. It can sometimes just add a new one. And the same really does apply to AI. So if you don't understand the service, the process, and the people, you don't really know whether AI belongs there or not. So the success we're expecting out of this pilot isn't just because we used AI. It was all the groundwork that the team supported us in beforehand. But, wow, an AI scribe to this team is really going to make such a huge difference. So thanks, everyone, for listening. And please do get in touch if you have any questions or you'd like to know a little bit more about our testing and what else we've been up to. Thank you.